Welcome to this SCG Health Gimme 15 Minutes education program for medical professionals. My name is Jennifer Searfoss, and I am the CEO of the Searfoss Consulting Group. To help you spell my last name, the company is also called SCG Health. We opened our doors in 2011, and we focus our client services on revenue cycle management and strategic planning in this post-health reform world. This presentation is Getting Paid for Medical Services, and we'll cover what you need to know about appeals, also denials, and a number of other timely topics. So one quick legal note, none of the information contained in this presentation should be construed as legal advice. I highly recommend that you contact counsel if you have any questions at all regarding the topics covered in these sessions. Also, if you have any other interest in the number of topics we have covered on our Gimme 15 Minutes YouTube channel, please check those out. We also do in-person conferences on many topics, including ICD-10 preparedness, compliance, and EMR implementation. You can learn more about what we do at scghealth.com. With that, let's go ahead and get started. And we're going to cover, again, a number of things about how to get paid for your services, but also it comes down to something called revenue cycle management. There's a number of topics we've already covered on our channel that are related to this topic, and I highly recommend that you check out the entire playlist. So let's first start with the claim generation, and it's almost the life of a claim so that we can have the basis to discuss how to get paid for services. So it first starts with patient scheduling, and so you're going to gather information about the patient and their insurance when they call in either as a new patient or established patient for the services and how to bill for it. After that, you should run an eligibility within 3 days of the upcoming services, and then of course once they show up you should run it again. As part of the patient registration and intake at the time of service, validate the patient information, again, document everything you have, which may include taking a scan of their identification card. The clinical encounter then happens, and then after the clinical encounter, the clinician will either dictate, transcribe, or document in an electronic health record, knock on wood, that's what you have. In doing that, it generates a super bill, which is, again, that list of the services that are performed at the time of service, and it should include the diagnosis codes related to the service. That super bill is either rekeyed or auto-generated from an electronic medical record over to the practice management system, which generates the claim. And the claim is then sent out electronically through a standardized data set that is established under HIPAA. We're going to talk a little bit about that as we get into the process. So here's really what you need to know, again, about what happens once a claim gets sent out of your office. It goes to a clearinghouse. It's basically a big mailing room, and it's going to figure out where that claim needs to go based on the information that you've entered. Now, that means that if you have the wrong information for the wrong health plan, and specifically the wrong payer ID, it becomes an issue and the claim could be rejected. Now, I do want to talk a little bit about rejection and a denial, and then talk more about denials. But once a clearinghouse sends the claim, it's received by the health plan. And then they're going to run a match. Now, matches are done on a proprietary algorithm established by each and every different health plan, and truly it is different for every health plan. So one of the things to keep in mind is that if it doesn't match to a beneficiary or it doesn't match to your practice, and again, it can be matched on a name, on a TIN, on your group NPI, it could be matched on your zip code. Very interesting what first matches, but if it doesn't match, it actually is going to be rejected. It's not a denial. It just means the health plan can't find you, and so they're not even going to process the claim. A rejection means that it is not a denial, so all of the rights that apply with a denial do not attach. Instead, a rejection should be resent in, and you will not have any issues with duplicate claims because it never was received. So if you're starting to see that you have no claim numbers, and when you call in there's no record of receipt of a claim, again, remember that likely had a rejection. Go back and look at why it was rejected, clean that up, and you can resubmit the claim. Now, once the plan actually receives the claim, and they will have what is an acknowledgement, that is a standardized transaction that's out there, and they acknowledge the receipt of the claim, they're going to process it. And they first will look at claim edits. The claim edits are going to be looking at, for example, was this a removal of an 11th toe? That's something called medically unlikely edits. Also, whether or not it's services that should have been bundled with other services. For example, you've got a surgical tray. Surgical trays are always bundled. So those type of services, they're going to check and see whether or not they were unbundled, and they will deny those services based off of the proprietary edits for each of the different health plans. Medicare is the only one that has the edits that are open and transparent. But then they'll also look at coverage policies. So for example, again, let's look at Medicare. Medicare right now only covers pap smears every 2 years for women unless they are at high risk, and then it's annually. So on a coverage policy, let's say that it's a pap smear that's within that 2-year period for a woman that doesn't have a high risk, that service would then be denied for hitting up against the coverage policies. And this is a true denial. We'll talk a little bit more about denials, but denials, again, you can appeal those denials, and each of those different appeal levels have different rates and regulations applying to them. Once the claim has been processed, they're now going to match it to a contract to figure out what the allowable amount is that's been contracted and agreed to. Again, for Medicare, this is much easier because all they're looking for is what is the allowable amount for your locality and then also the site of service. But for other health plans, this does become more difficult, especially if you have multiple contracts depending on where your office is located. They then are going to send back the remittance and payment. Remittance is going to be on an electronic EOB. We also call that the electronic remittance advice. If you want to know numbers, that's your 835 standardized HIPAA transaction. And then the payment is going to come back as something that we now know as EFT, the electronic funds transfer, which is really direct deposit. I'm going to talk more about both of those. What's notable at this stage, too, is that you actually can run something called an RTA, depending on your partners, which is a real-time adjudication. You can actually process a claim within 5 seconds of sending it out and know what's going to happen with the claim. It's really great. The only downside is that you still have to wait 21 days to get paid by most health plans, 14 for Medicare. So just remember that, RTA is great to know what's going to apply there, but it doesn't expedite the plan payment. It does allow you absolutely to collect the correct amount from the patient at the time of service, though. So it's something absolutely you should look at from your office's perspective on timely payment. The last thing to know, again, is that when that response is routed, it's going to be routed by the clearinghouse. So again, the clearinghouse, if you're running into problems, usually look back at the clearinghouse for your issues. So again, as I said, when a claim is processed, you're going to get that 835, that electronic remittance advice back, and the patient receives a copy of it known as an EOB. And of course, that is the document that looks mysteriously like a bill, but it is not. I want to talk more about that actual document because it's incredibly important, and when you're looking at payment, you really need to mine the information that's there. Now, with EFT, you are going to get a trace number. The trace number is what allows you to match back and do your AR recoupments and also just balancing your AR and your sheets. So for your accounts receivable, make sure that you are looking at those trace numbers. This is something that was fixed recently, so again, definitely check that. And then double check whether or not the EFT amount is the allowable. Now, auto-posting is what I'm sure all of your vendors has told you what your system is supposed to do. It remains elusive. Work with your clearinghouse to find problems, and honestly, this is where you're going to actually push and have them solve for issues that you're having on auto-posting. Now, the last thing is on billing. Remember that your patient responsibility, and here PTR is the acronym I'm using, but for your PTR, remember, collect as much as it is you can at the time of service, because once that walks out your door, you're not really going to be able to collect money. Patients, time and time again, just don't pay doctors. It's the last thing that they pay for, because the mortgage comes first, along with electricity and, of course, cable. So make sure, too, that the allowable that's posted on your electronic benefits is actually, that statement is the allowable amount. Incredibly important that you do this. So your tips and best practices, again, to get paid what you were supposed to get paid, you have to know your fee schedule. Match what's paid, both the patient responsibility aspect and the plan aspect, to your allowables, and make sure that it is exact. Also, don't let reconciliation get away from you. When you are going back and looking at your AR and what's coming in the door, make sure you're doing it weekly. The longer you wait, if you try to do this once a month, it means that you're honestly delaying your entire AR by days and days. So do it weekly, know those areas, and make sure that you have staff that are following up. We're going to talk more about the CARCs and RARCs, but if you can find out why you're getting denials, it's incredibly important that you work them on the first side so that you can increase your amount of having what's known as a first pass payment rate. And then also, this is the biggest thing, is that in every practice, somebody should be double checking and verifying that the actual amount that was received on the EFT statement is what was deposited in the bank. It's amazing how that gets off. We still don't quite know how it happens, but oftentimes there will be a discrepancy. And so you need to make sure that the amount that the EFT statement says is the amount that was deposited and it actually was deposited. So let's talk a little bit more about these CARCs and RARCs. These are one of my favorite areas of strange things to talk about. So this is the claim adjustment reason codes and the remittance advice from RARC codes. This gives you an idea of why claims are denied. Remember, this is different from rejections and denial. We're only talking about denials. But these are it's a statement that will appear at the bottom of all of your electronic records, also the print statements that are coming back, your 835s. This is where it will give you information of what's going wrong. So just want to share with you some of the top codes. The CARC, so again, these are going to be your claims adjustment codes. What's going on? So CARC 251 is basically that they don't have enough information and they are missing information for the service. They want more information on the claim, or depending on, again, the code that's there, it actually could be that they're missing additional information, and so an attachment needs to be sent back in. Now, again, why it's so important on denial codes to be paying attention to this is that right now we do not have a way to send an unsolicited electronic attachment. This is how you get the solicitation to receive the information back and respond with an appeal, of course, on paper, but you're going to respond with this information. Now, a couple of health plans do actually have it electronic. United Healthcare is one of them. So definitely look at your electronic aspects because it does allow better tracking and confirmed receipt. Now, CARC N252 is very similar, but it really is driving down to the fact that they need a set of documents, that they are looking for the parts of the medical record. So 251 is specific to they're needing more information on certain aspects. For example, maybe it's an incomplete or invalid physician signature because it wasn't on file. But 252 is really specific on the documents that are being needed. Now, CARC 16 is that generally there's going to be something wrong with the claim on its face. There's something wrong. Either the ordering physician's number is not there, or the patient's address is wrong, or the gender is wrong. There's something wrong on the face of the claim. Three other ones to think about. So CARC 50, these are going to be non-covered services because they are not deemed to be medically necessary. So it could be services that are never covered, for example, Botox that is cosmetic in nature, but it also could be things that are considered experimental and not medically necessary, or areas that the health plan basically says you need to prove medical necessity first, either through prior authorization or with medical records. CARC 96 is a little different. And this is going to be a denial for another reason or policy. Medicare really uses these. So for example, for CARC 96, one of the top ones we normally see is that there's only one visit per specialty allowed in a group. We often see this even though the specialties might be different, but the group tax identification number, the TIN, is the same. So again, it would be able to be appealed and overturned on appeal. But know that, again, these are the automated first-pass claim issues that oftentimes you are able to fix because, again, on certain ones of these, it's able to be fixed, but others possibly not. So CARC 170, this is when this is a service that can't be performed by that type of provider. Also, maybe the licensing information is limited and they can't perform those services, so it might be a physician assistant or a nurse midwife. Also, you could have, let's say, a podiatrist performing services that are outside of their scope of specialty, those type of things. And then also, it requires other parts of licensure or supervision. So it gives you just a brief introduction on the importance of these codes and actually paying attention to them, because if you do, you can actually go and change your entire revenue cycle management system and really squeeze down all of the claims that are being denied and improve your overall first pass payment. So three other topics I wanted to bring up. One is timely filing. Oftentimes this is covered in your contract. Go and check that. I do highly recommend you check out, there's another webinar on just generally what are contracts and what are health plans. Please check that out in the Give Me 15 Minutes archive. I really recommend you learn more about the contracts. But with that, timely filing is again in the contract, and it's going to state either in the contract or in the handbook how much time you have to submit a claim. Every health plan is different. Generally, they're going to range from 90 days, and it's 90 calendar days, not 90 business days, all the way up to a year. So again, just check that out. Sometimes also state law will impact the contract, and many states have a mandate from 120 to 180 days. But again, my normal default is trying to get a claim out absolutely within 90 days from the date of service. How can you make that faster? How can you find out? And again, as I mentioned, that real-time adjudication is a way that you can find out quickly if you're sending it to the wrong health plan. The last one, too, is your appeal deadline. How long do you have to appeal? Because, again, if you don't submit your claim in time, it's going to be denied. But also, if you don't send your appeal in time, it's also going to be denied. When you do anything on an appeal, please make sure, this is the best tip for you, put the name of the patient and your tax identification number on every single top. And I do mean the top within the first half inch of the paperwork, because when it's scanned, that's oftentimes all that the folks who are looking at it are going to find. And if things get separated, it's how you actually make sure the information is collated correctly. Please, please, please take, if nothing else from this session, that is a really big deal. Put the name of the patient. If they have any patient identification number, include that, and then your tax identification number. Also, if there's a claim number, I highly recommend you add that as well. So pending for records, I mentioned this earlier, it is one of the top carks that you'll see on claims denials, that they're basically pending it for records. So again, that top of the documentation best practice I just mentioned, continue that for any time they do a request for records. But in your current environment right now, again, this is all going to be generally paper-based. In the future, we are going to be moving to electronic attachments. So that's the good news that I have for you. We do have the operating guidelines. It's just mandated for implementation next year. So hopefully we're going to get there. So my last thing I wanted to talk about is recoupments. And so this is where a health plan comes back and retroactively denies something that they already paid. So for example, I'll give you one here for a July 1st, a July 2nd, and then a disputed service that's on July 16th. And it is a true retroactive denial. They paid for it, and then they're going to come back. Now, Medicare can go back and look as far back as 5 years. They have proposed a 10-year look back that would be consistent with the true fraud, where there's criminal intent for fraud for those guidelines. But a payment that's received on July 6th for these 3 dates of service, how do you figure it out? And to be honest, it's incredibly difficult if you have that. So make sure, again, when you go back and are doing reconciliation, you're doing it once a week, because that's going to be your best practice. But likewise, you're double checking to make sure that the total amount that you're receiving on the check matches what you should have been paid. Because if you're seeing a dispute on it, that means that there was a recoupment, and you have to go figure out where it is, and that you're able to work it out in your practice management system. We covered a number of really important topics here. Of course, if you have any questions, feel free to email me directly at jen@svghealth.com. I also hope that you learned something new, nothing else. Put something on top of every single page that you send in on an appeal, because it really will help tracking and ensuring that your appeal paperwork stays together. So I hope that you enjoyed this presentation. For those of you who are watching the video archive, please remember to rate this video. To receive notices about upcoming Give Me 15-minute programs and other educational sessions, please sign up at svghealth.com. Thank you for joining me for this 15-minute education program. This concludes the presentation.